Welcome to episode 237, Resilience in Action, Why Some Bounce Back from Trauma and How to Help Others Do the Same, featuring Dr. Donald Meichenbaum, licensed clinical psychologist. Make sure to subscribe to be alerted about future episodes. By Clearly Clinical, learn, grow, shine. This episode is proudly sponsored by Berries, AI assistant for therapists, creating personalized notes and treatment plans. Try 20 sessions free at heyberries.com. Hello to our listeners. My name is Beth Riaz, and I am beyond honored today. I am joined by Dr. Don Meichenbaum, and he practically needs no introduction. Dr. Meichenbaum has been part of our field, instrumental in the field of psychotherapy for decades. He is research director for the Melissa Institute for Violence Prevention. He is one of the founders of cognitive behavior therapy, and it's hard to imagine psychotherapy today existing without Dr. Meichenbaum's work. Thank you so much for joining us, Don.
Thank you for inviting me and giving me this opportunity to speak to your audience. The topic for today, I gather, has to do with the concept of resilience that I've been heavily involved in. You mentioned the Melissa Institute. Let me just comment on that to begin with. Melissa was indeed an undergraduate at University in St. Louis, American University, and she was carjacked and brutally murdered. 28 years ago, her parents decided to transform their pain into something positive that could come of it, and they created an institute in her name to prevent violence and treat victims of violence. And for the last 28 years, I have been the research director of this institute. It's per se not a hands-on direct institute, but apropos of this presentation, it is designed to give science away, to make therapy processes more effective and the like, and to prevent violence. So one of the things that I hope your listening audience will come away with is an invitation to visit the website of the Melissa Institute. It's called www.melissainstitute, all one word, .org. And on there you will find additional papers by me on this topic, as well as many other presenters. I should note that in the capacity of doing the research director, last week I actually presented to 350 mental health workers in Ukraine, war-torn country, on how to bolster resilience in spite of all of the stress. The other item is I have been for the last 2 years training psychotherapists in cognitive behavior therapy. The last giveaway that I have for your audience before we get to the topic at hand is I wrote a book called Roadmap to Resilience. And this book I have put online for free, and your audience is invited to download it by going to Roadmap to Resilience, all one word, .wordpress.com. It has been downloaded for free by 51,000 visitors in 138 countries. So in one capacity or another, this has been a general topic that I have been involved in many ways. I will take the liberty of just sharing one last item, which is more personal, that highlights for me my involvement in this topic. 2 years ago, my wife of 58 years and I were vacationing in Florida, and a tragic thing occurred. She was actually run over and killed. So I have dealt with and presented on the question of grief and how people cope with it. Moreover, in following up that particular event this year in January, my heart stopped for 14 minutes. So this near-death experience of the ventricular tachycardia which pumps blood to the body, is something I have endured. So between the death of my wife and my own physical health limitations, I have lived through this period of time. I'm 84 years of age and still active in many ways. In fact, I just co-authored a book on domestic violence and how to reduce the likelihood therein. So thank you for the opportunity to bring to the attention of your colleagues all of this kind of material. And I'm more than happy to answer any queries you have concerning the concept of resilience and how we can bolster it in response to the demands, victimization, and traumatic events that people are experiencing.
Amazing. On the topic of resilience, this is one of those words, at least in my mind, that we weren't talking as much about 20 or 30 years ago. Um, there have been different concepts that have evolved over time when we're looking at what mental wellness looks like. Can you define for our audience, like what is resilience and why is it important?
Okay, that's a good introductory question. Resilience is the ability to bounce back. It's the ability to deal with ongoing adversities that individuals might experience. The really fascinating aspect of all this is that if you look at the research literature on how people respond in the aftermath of traumatic and victimizing experiences. In fact, most people are impacted by those events, but 75% of the individuals go on to evidence resilience, the ability to bounce back, the ability to carry on life and not develop psychopathology. 25% of the population, whether you look at the exposure to interpersonal violence, terrorist attacks, school shootings. If you look at the response to natural disasters like the recent hurricanes, if you look at the loss of life of significant others, in response to that, while most people are impacted, only approximately 25% of individuals develop some form of clinical psychopathology like PTSD or depression or anxiety, or go on to develop addictive behaviors and interferes with their behavior functioning. So if we as mental health workers are going to be effective, the key question is what distinguishes the 75% who quote unquote make it versus the 25% of individuals who get stuck. Clearly, our efforts as mental health professionals should be to incorporate those elements that facilitate or bolster resilience on the 75% group. It is also interesting, since I've had various debates with people like Bessel van der Kolk, who wrote The Body Keeps Score, who appropriately noted that in response to exposure to victimizing traumatic events, that 25% individuals will not only have psychological, but also have biological or physiological responses to it. However, this is the exciting news, and therefore it's worth noting that the 75% of the group who evidence resilient also show physiological benefits. That is, the body keeps score both of trauma and also of resilience. That observation leads me to highlight for your audience that resilience and for PTSD can coexist. These are not either or phenomena events. In fact, people could be resilient in one area of their lives and not in other areas. And moreover, resilience can be evident at one time in life and not at other times. So we need to think of the concept of resilience as a kind of transactional concept. And not only can you have resilient individuals it becomes apparent that you could also have resilient families, resilient communities, resilient organizations. And therefore, it behooves us to wonder how we could bolster resilience across the entire lifespan. And I'll comment on this during this interview. Hopefully, that gives you some inkling of my approach towards resilience, and we can go into more detail on what distinguishes the 25% versus 75% that informs psychotherapeutic efforts.
Thank you. And thank you for that overview. When you were speaking about it, my mind was jumping back to the research about adverse childhood experiences and that kind of fascinating perspective on why some folks will work through it, will continue to grow, and
Right.
why some folks don't. Or have more difficulty with it. I would love for you to break down that 75 and 25% and kind of the differences within.
Okay, well, first of all, from my perspective, each of your members of the audience are not only Homo sapiens, but each of us are also Homo narrans. A Homo naran is, in fact, a storyteller, and then our lives are filled with stories. And I will propose, when we look at the distinction between the 25% and the 75% group, that it's the stories that we tell. It's not that bad things happen. Bad things happen to lots of people. It's what lingers from those events. It's what conclusions do we draw about ourselves and the world as a result of having been exposed to. And it's the accompanying coping mechanisms that go with each story that is going to distinguish the 25% versus the 75%. Let me break that down for you and have your group appreciate that the good stuff that I'm going to describe is more powerful than the bad stuff in influencing the outcome of exposure. In fact, if you look at children who have been exposed to ACEs, that are diverse childhood experiences, 1/2 to 2/3 of them, in spite of whatever abuse they've experienced, physical, sexual, emotional, exposure to violence in one form or another in the family, school, or community, that 1/2 to 2/3 are going to be able to make it. And what becomes important, apropos of work by Sherry Hamby and others that we've presented and the like, they have indicated that it's not only ACEs, but PACEs. PACEs mean it's the cumulative impact of protective factors. So we could start to look at what are the protective factors and to see the degree to which they have been incorporated into our psychotherapeutic domain. Let's begin with the 25% group and see what are some of the building blocks that contribute to that form of psychopathology that may develop. Individuals who have been exposed to ACEs or other kinds of traumatic and victimizing experiences tend to see themselves as victims as compared to survivors. This is a central tenet of the nature of the story that they tell themselves and that they tell others. In fact, it's interesting to note that as one attends to the stories of people who've been victimized, certain characteristics stand out. For instance, one of the characteristics that stands out is that language is often inadequate to describe all that they have experienced. And in some sense, the client becomes a kind of poet of sort. And they often use various forms of metaphors and the like to describe the lingering impact. They might say, for instance, that they are a prisoner of the past, or that they are victims of their emotions and feelings. They may engage in various forms of negative thinking, of catastrophizing, and the like. In fact, there's research to demonstrate that people who are stuck with PTSD engage in a lot of negative thinking. Another characteristic about that group is that whatever they've experienced, they've often kept it a secret. They have not shared it with others. For instance, there's longitudinal studies of individual women who have been raped, and they have never shared that incident with others. It turns out that those individuals who keep it a secret tend to have much more difficulty in adjustment. And note that the sharing does not have to be with a therapist, and moreover, that the sharing does not even have to be in the form of language. It may be in form of some expressive art or other kinds of values. Clearly, as we will see when we get into the area of therapy, that creating a trusting, compassionate, empathic environment with clients is going to turn out to be critical. In fact, it turns out that the quality of the therapeutic alliance is 3 or 4 times more important in influencing outcome than is the specific kinds of treatment procedures that people use. Moreover, I'll have more to say about this therapeutic alliance down the road. Getting back to the components, therefore, the nature of the stories that people tell, the nature of the thinking processes that people engage in, the degree to which the client keeps whatever victimization experience they've had as a secret, all contributes to the likelihood that people are going to fall in a 25% group. Other components that have emerged is that these people often try to intentionally avoid thinking about or experiencing that same kind of victimization event. We know that, in fact, that kind of intentional avoidance behavior on the part of individuals actually has a boomerang effect and actually leads to greater intrusive ideation. Moreover, as we proceed, we will see that these individuals tend to have much more social comparisons, engaging in attributions, and having belief systems that tend to reinforce the very form of psychopathology. They may engage in a variety of behaviors of coping efforts that actually make their situation worse. For example, such as addictive behaviors or engaging in some kind of stimulus-seeking behavior that puts them at high risk or jeopardy. I can go on, but if in fact the audience goes to my book on Roadmap to Resilience, it will enumerate many other kinds of components that contribute to 25%. Let's look at what characterizes the 75% of individuals who tend to make it. First of all, it's important to appreciate, apropos of the work by Ann Maston and others, there's nothing extraordinary about resilient. And she describes it as a kind of ordinary magic that individuals evidence, and that in fact, all clients can build more resilience into their repertoire. This will represent an important component of how therapists should spend their time. Social supports are a key ingredient of what facilitates resilience in individuals, families, communities, and the like. And it's important for us to recognize that under social supports, we're talking about different kinds of supports. We're talking about information that helps individuals. We're talking about physical supports of people providing the kinds of wherewithal to survive, the basic needs. And then we're talking also about emotional supports that people have also found invaluable. And in fact, individuals may have gone to different folks for different forms of social support. And we can start to query our patients in terms of their presentations in clinical settings of not only what happened to them and how has it impacted on their lives, what have they tried in the past to improve their situation, what works, what doesn't work. Moreover, we could find out from them how would they know if in fact our therapy sessions have been beneficial in bringing about change, who else would notice such change, and can they foresee anything that might get in the way? Note what I've just done. I've highlighted that for the therapist, for your audience, the most valuable skill they have is the art of questioning. And in fact, if they go to the Melissa Institute website, they will see a list of what I consider the best questions a therapist could ask. And note, if you go back to the questions that I just enumerated, every one of those questions are a how and what questions. How are things now? How would they like them to be? What have they tried? What works? What doesn't work? As evident by how could I, the therapist, be of help to them? Moreover, what should be our treatment goals that nurture hope? If the client improves, what would look different? What would other people notice? And lastly, what, if anything, might interfere with regard to their performance? Note, every question I asked was a what and how. What are we doing? We're looking at the nature of the building blocks that contribute to the 75% of individuals who evidence some kind of resilience. Over and above social supports that patients bring into our sessions that they can access, we as therapists also have to act as collaborators in setting treatment goals, having short-term, intermediate, and long-term goals, having SMART goals, specific, measurable, attainable, relevant, and timely goals. Each of those will nurture hope. And as we will see, a building block for resilience is some form of hope that we can help nurture in our clients. Another important element contributes to this is some form of control of negative emotions, so that one can look at the variety of tools that therapists have in terms of teaching motion regulation skills, distress tolerance skills, self-soothing skills, mindfulness activities, relaxation procedures, interpersonal coping skills, all become critical in facilitating that 75% group. Closely aligned with the notion of these kinds of hope engendering kinds of personal goals is for the client to appreciate that some of the stressors that they are likely to encounter are changeable or potentially changeable, and that there are some kinds of stressful events that are not changeable. This became apparent last week when I presented to the mental health community in Ukraine. Clearly, the uncertainty of bombings and the like, death of loved ones, call for different kinds of coping responses than the kind of problem-solving techniques that they need that are just routine generated that they could apply. Another kind of element that contributes to these form of benefits is some kind of meaning making. Viktor Frankl, who wrote Man's Search for Meaning, I hope that everyone has a chance to have read this, was the Holocaust survivor. And one of the things Frankl highlighted was that we as human beings can deal with almost any kind of any kind of traumatic event, as long as we have a why in our lives, some sense of meaning, some sense of purpose. In fact, in my book on Roadmap to Resilience, as well as on the Melissa Institute, I have an entire section on how to integrate spirituality and psychotherapy. That the use of some form of religion and the like is often seen as a therapeutic domain, a sense of community. In fact, if you look at people in the United States who've been exposed to traumatic events in one form or another, some form of religiosity or spirituality is the major dominant coping response. In summary, What distinguishes the 25% versus the 75% of individuals who make it? Part of it has to do with individual, social, and collective coping responses in response to the nature of the trauma and victimization. It has to do with the number of protective factors that people are exposed to or that they generate, either individually or collectively. So, in terms of meaning making, we can start to think of the variety of ways people cope with tragedy. So, for example, in response to Melissa's tragic death of her carjacking and suicide, the question became, how does her parents and siblings cope with the aftermath of that event? How do they not get stuck? That doesn't mean that they don't have ongoing grief. They may not have ongoing anger with regard to this. But therefore, one of the things that becomes interesting is how they created an institute in her name. They could try and transform their pain, their emotional pain and loss, into something good that could come of it. There are innumerable examples of such organizations. You can think of the Trevor Project with regard to the way in which his parents tried to reduce the likelihood of suicide among adolescents by creating this kind of efforts. There's Mothers Against Drunk Drivers. I can go on and on, enumerating the variety of organizations whereby they have transformed their kind of pain into something that's very beneficial. In fact, when your audience goes to my Roadmap to Resilience workbook, and I noted was free on the internet, Roadmap to Resilience, you will be able to see that I have enumerated a variety of physical, interpersonal, emotional, cognitive behavior, and spiritual kinds of coping responses. Therefore, as we will see, each of these kinds of building blocks has specific kinds of treatment implications that I want to discuss with you.
Amazing. Thank you. There were so many pieces that you just shared that I think are so impactful. Those questions and this idea around meaning making. To zoom in a little bit on the 25% folks, in the research, are we able, either as clinicians or just as human beings who are in that 25%, are we able to move into resilience?
Well, as I mentioned, Anne Maston indicated in her initial work in the area of resilience that everybody has the potential ability to build more and more resilience into their repertoire. Clearly there are a variety of factors that act as obstacles towards that movement. And therefore, it behooves the therapist and the client to collaboratively identify those and address them so that the individual may be living still in a very high risk environment. I mentioned that I was just finished a book on spouse abuse and domestic violence. So, for instance, a number of women who are victimized, they are in a behavior of sort of acting as one might call a siege mentality. And in fact, these women, when they are trying to leave the escape from the avoidance behavior, are most high risk of being killed. There are agencies and the like that are not supportive. There are more animal shelters in the United States than there are shelters for domestic violence. So therefore, clearly, we as therapists need to show great empathy with the people who are struggling to get into the 75% group. And not only do we need to show great empathy, we need to attend to what are the potential real as well as thought-provoking barriers that people have. An individual may be stuck, quote unquote, in a setting that keeps them from exiting, changing, or improving their own level of resilience. Um, Therapy is a very noble profession. I have very high regard for therapists and their responsibility in trying to move people. I think one of the messages I want to get across is that the degree of hope is not only critical for patients, but it's also critical for therapists. The approach that I have is very strength-based. No one leaves my office without my getting what is called the rest of the story. And in fact, people have written about the end of trauma, you know. So in fact, if you go to the Melissa Institute, you will see that I have recently presented more detailed presentations on this topic of the core task of therapy. One of the things that's fascinating is that 25% of therapists get 50% better results and have 50% fewer dropouts than their colleagues. So maybe we could talk a little bit about what characterizes that 25% group so that your audience can become members therein.
Amazing. You are alluding to deliberate practice and feedback informed treatment, which is one of my first clinical loves. And our listeners know that I could talk until the cows come home about the importance of rapport and creating a culture of feedback and security and safety. I would love for you to talk more about that element because we have been, as a field, for decades moving into, oh, well, you need to do this treatment, use this acronym in order
Right.
to provide effective care. And what I think is so beautiful about deliberate practice and feedback informed treatment, this research that you're talking about, is that it complements every single model and it makes everything more effective. And it actually allows us to do the things that we set out to do and keep clients in treatment and prevent early dropouts and help them achieve their goals. And the documentation nerd part of me is all excited when you're talking about the importance of treatment planning, because it for many of us, we hate paperwork. And it's also like, well, it's bigger than that. It's more than just these checkbox paperwork things we have to do. This is actually about improving care. I would love for you to talk about those elements and expand on that, please, Doctor.
Well, we are both fans, similarly, of feedback informed treatment. In fact, the Melissa Institute had Scott Miller when he was developing his scales to assess for feedback. And as he notes, one of the things that's interesting is that therapists in general do not ask their patients systematically, in terms of the art of questioning, how they can work together, and whether you want to use the Miller kind of rating scales or whether you just want to use the art of questioning. My preoccupation has to do with generalization. That is, I'm preoccupied with not only how people improve in therapy, but what is it they take away from the therapy sessions that they're going to apply on a day-to-day basis. In fact, one of my favorite questions is the following. I say to the client, Beth, let me ask you something a little bit different.
I'm ready.
Do you ever find yourself out there in your day-to-day experience asking yourself the questions that we ask each other right here in therapy? See, that's a very clever question. I'm asking, do you, the client, ever find yourself out there in your day-to-day experience asking yourself the questions that we ask each other right here? And what I'm conveying to you, the patient, is that I want you to take my voice with you.
Yeah. Pocket therapist.
That therapy is really the art of questioning. And I want you to go out there and ask yourself the questions that I would be asking you. I want you to put me out of business. I want you to become your own therapist. And I have to ask you at the outset, I say to my clients, let me explain to you what therapy is all about, what the research indicates. Okay? We we have a lot of tools of these that are out there that we could use in your case. But the real active element of therapy is how the two of us connect. The real key element is how can I be of help to you? How can the two of us establish a relationship that helps understand with as much empathy and compassion as I can muster, as much as I just engender trust, to have you share with me these kinds of elements and what you've tried so far and what I could do to help you. Now, along the way, I want you, the client, to understand that I will ask you on various occasions how well I'm doing, how well we are doing. The answer to that question means that we can change things along the way so you feel heard, so that I'm talking about that which you want to talk about, that we have a fit between you and me. Does all this make sense to you?
I love this stuff. It's so simple, and it's also, I think, really different from the way that many of us have been trained over time, where we were therapist as expert, and the Duncan and Miller research kind of turns that on its head, and it's so much more collaborative, and that it creates this culture that is designed around seeking feedback. And
Right.
this is where I'll nerd out for a moment. The part that I think is so cool, when I've given feedback informed treatment trainings, one of the questions that comes up is like, isn't that awkward to ask a client routinely, like, how are we doing? How am I doing? What can I be doing better or differently to support you? And I love that the research has found that no, it's not awkward. The clients like it, and that it improves the relationship.
In fact, I co-written an article with a guy named Scott Littlefeld, who unfortunately died, called How to Spot Hype in the Field of Psychotherapy. And there are a number of questionable procedures. In fact, if your audience goes to the Melissa Institute, they can read the award-winning article on how to spot hype in the field of psychotherapy. And in there is a consumer's checklist of 19 items. So there are innumerable procedures, especially in the area of PTSD, that are called acronym-based therapies. In fact, I am convinced that people create the acronyms and then they create the therapies that fit the acronyms. So therefore, one of the things that characterizes that 25% group of individuals is not only these elements I'm going to enumerate, but it's their ability to spot hype in the field of psychotherapy. So I come with goodies. The holidays are about to arrive, and I come with the Melissa Institute. I come with a free copy of Roadmap to Resilience, and I come with a spirit of hype articles. And let me conclude our lecture just with a few other elements of what I think I would like these therapists take away with them. In fact, I have recently created 2 legacy courses, each of 10 hours, and they are: what are the core tasks of therapy, what makes someone an expert therapist, and how you could apply those core tasks to a variety of clinical problems of anxiety, depression, PTSD, addictive behaviors, and the like. And we have kept the price of these 2 courses minimum. And I should note that all of the funds, all of the proceeds for these 2 legacy courses are going to go to the Melissa Institute in memory of my wife, who was killed. And therefore, I invite your audience to visit the Melissa Institute and to read about these courses. I poured a lot of me into it, everything that I know of doing over 50 years of psychotherapy and research in this area and being a developing of cognitive behavior mod. Okay, let me conclude with just what characterizes these 25% group and relate it back to resilience. So the first building block of what characterizes these therapists is the ability to develop, maintain, and monitor the quality and nature of the therapeutic alliance. That's where your feedback-informed treatment comes into play. That's where the art of questioning comes into play, and the like. The second kind of core task that characterizes these expert therapists is collaborative goal setting. That is, you need to develop smart treatment goals with your patients. It's not only a matter of their purchasing friendship and self-disclosing problems, but we need to have them move off the pot and really think about where in their life they're going to change. Okay, whether it's emotional, cognitive, behavioral, spiritual, or the like. The next kind of element that is key for these therapists is the need to help clients appreciate a form of psychoeducation. They need to see the degree to which there's an interconnection between the way in which they appraise events, the accompanying feelings, thoughts, and behaviors, that they are not a mere victims of feelings and thoughts or circumstances, that I, the therapist, try and nurture a personal agency in them. So I have a very specific way of conducting this psychoeducation that I'll like to convey. So I convey to the clients that whatever anecdote they share with me fits a kind of clock metaphor. So I say to the client, it sounds to me, and correct me if I'm wrong, see if I picked up on. And at this point, I put my hand actually at an imaginary 12 o'clock. And what 12 o'clock represents, Beth, are either external or internal triggers for that specific anecdote that they've shared with me. So the external trigger may be what people said or did, or what they didn't say or didn't do. Or an internal trigger may be some kind of intense emotion, flashback, nightmare, some urge to drink or what have you, okay? And I get you to share the examples of the triggers. So I ask you, given what you just described, can you tell me a little bit more about what was going on beforehand? And I try to ascertain with you the kinds of triggers in that particular setting. Then what happens is I then move my hand down to this imaginary 3 o'clock. And I say to you, Beth, can you share with me the kinds of feelings you had in that setting? How'd you feel before, during, and after the event? So that is an occasion for you to close more of that. Now, some clients will say, I don't know. To which either client, either therapist say, I don't know either. How can we go about finding out? Okay? The other thing is if they do report an emotion, I then view emotions as a commodity. I say, what'd you do with all those feelings of anger, depression, anxiety? I drank them away. I got my gun. So you do something with emotions. Think of them as a commodity. And then I ask in an artful way my questions were if you do that with these emotions, what is the impact? What is the toll? What is the price you would otherwise pay? So impact, toll, price you and others pay is a standard question I ask. However, the client may say, I don't know. To which I say, I don't know either. That is, I, the therapist, do not have to be a surrogate frontal lobe for my clients. I don't have to show them how smart I am, okay? And then I slowly move my hand down to 6 o'clock. And the 6 o'clock is what? It's the nature of their thinking process, okay? It's the automatic thoughts they had or images in that setting. It's the thinking style that they've engaged in. It's the developmental schemas, the nature of the beliefs that they have. I'm unloved, I'm a burden on others, whatever the nature is. And I'm going to help them explore the nature of those thought processes. And then finally, I come up to 9 o'clock. And what is 9 o'clock? The behavior and resultant consequences of how people respond. So what have I done? I've listened attentively to your story of woe. May have been a recent event or may have been something way back then. Okay? And I am now in the midst of breaking down your story of woe into 12 o'clock triggers, external, internal, 3 o'clock primary and secondary emotions, and I'm going to treat it as a commodity. 6 o'clock, the nature of their thinking process, and 9 o'clock, the behaviors and what did they do and how did people respond. And here's the key. I then say to you, Beth, it sounds to me, correct me if I'm wrong, that this is just a vicious. And on the word vicious, I put my hand at 9 o'clock and I slowly move it around this imaginary circle without finishing the sentence. And I can guarantee you that there is a remarkably high probability that your clients will finish the sentence by saying cycle or circle. Now, if you've gotten to 6 o'clock and they have not say it, you say it. You don't sit there going like charade. Small words, 2 syllables, just okay? And they're going to say vicious cycle. And you're going to say vicious cycle? In what way? Are you telling me that when this event occurs at 12 o'clock, you do what? 9 o'clock? And that makes you feel how? At 3 o'clock? And then you have the thought of that even makes you vision. So you don't have to go around in one way. You can go around in different ways. And then I say to the client, Beth, do not change anything. Between now and the next time I see you, try and figure out whether this vicious cycle is something you do. So the client's likely to come back and say, I do it. And you say, you do what? And they say, I do the vicious cycle. Okay, tell me about it. Okay? So what I'm going to do is have them appreciate the interconnection between the appraisal of events, feelings, behaviors, and resultant consequences. And then we're going to ask them the question, given the vicious cycle as you described and its impact, its toll, its price you and others pay, what can we do about it? Your client does not have to be a rocket scientist to say that one of the things that maybe he or she should do is break the cycle. And you go, break the cycle? That's interesting. How are you presently going about breaking the cycle? And what they're going to do is to realize that their present behaviors, their drinking, their avoidance, their anger, are all present attempts to break the cycle. And here's the really good news. They are in the presence of a therapist who could help them develop more resilient, more positive ways of breaking the cycle. In short, Beth, there is nothing that your clients tell you. There is no relative that you have in your life whose stories that you have to listen to cannot be broken down into a clock. This is life, okay? More only that, people have often a variety of coping skills that they've already evidenced in spite of that they bring to therapy, and that's where the strength-based approach comes in. Because I can not indicate that they were not starting at point zero, but that they have a whole variety of things that they've accomplished, talents that they have, competencies, relationships that they developed that can be brought to bear in developing this. So I get paid to listen to people's stories. So do you. Therapy isn't some really sexy business, okay? And the interesting question is, why is it telling me as a therapist their stories more effective than they're telling their bartender, their hairdresser, or their Mother Earth figure? And what makes me more effective is I have a way of retelling their story in terms of a clock that nurtures resilience and strength. I hope that your audience will at least consider the legacy courses I've developed, because I have many clinical examples of how these tools can be used. Does that make sense?
It does. Knowing that many of our listeners will be tuning in via audio, is there a website that we can refer them to where they can see a visual representation of the clock?
Yeah, if you go to, it is that I did something really spectacular. I just moved my hand from 12 o'clock to 3 o'clock to 6 o'clock to 9 o'clock. But if they go to the Melissa Institute, they will be able to see interviews with me that document this. And what I haven't had a chance to really include in this presentation is all of the material I have online on the Melissa Institute on how to bolster resilience in high-risk children, depressed, suicidal adolescents. And given that I'm 84, I have just recently presented on how to bolster resilience in the elderly. So, I'm looking around for that kind of continuing resilient engendering behavior, especially since had the heart stoppage for 14 minutes.
Absolutely. With the few minutes that we have left, I would love for you to speak a little bit about some of those populations that you just named. Just kind of Easter eggs to give us something to think about and chew on, and then the opportunity to go and look at some of the resources that you've recommended.
Well, for example, in the work with the elderly, for instance, we know that loneliness is one of the major morbidity factors, in terms of, it's more high risk than smoking or other kinds of variables. So clearly, some kind of social supports in that domain. Another important predictor of resilience in the elderly has to do with physical activity. There's a fair amount of work on couch potatoes and how long you sit and watch TV as compared to getting out, leaning to morbidity and mortality. There's a notion of how to deal with prolonged and complicated grief, especially with the loss of significant others as you become elderly. So there's a real need for therapists to view some of these emotional responses as normal reactions instead of pathologizing them. If you go all the way down to my work with children, high-risk children who have been exposed to uh, various adverse childhood experiences, I discuss in some detail what a trauma-informed school looks like, the critical role of school connectedness. We often ask young people, if you were absent from school today, who besides your friends would notice that you're missing and would miss you? That's an interesting question that pulls for the degree to which someone in the school has a positive relationship with that youth. And if you look at our work on these kind of interventions, we have a fair amount of what is called bystander interventions that we have. In fact, in response to police shootings and the like, the George Floyd incident, we created a whole program on bystander interventions, on how other policemen could have intervened there. In fact, that program has been published in the Chief of Police magazine. So, if your colleagues go to, the Melissa Institute, and they have a free weekend, I can fill it up with them on each of these populations that I've written handouts for, as well as not only me, but we have each of the people gave conferences, and one of the things is to nurture some kind of flexibility. There's no one right way. There's no algorithm to move from the 25% group to the 74% group. We did a recent presentation with a guy named George Bonanno, who wrote a whole book called The End of Trauma. And for all of those colleagues of yours who are in high risk areas, there is markedly hope that goes from 25 to 74% group. And it's our job as therapists to help people in that journey. We should have another hour interview and I can cover that topic for you.
Amazing. I think you've presented so many concepts today, an amuse-bouche, to kind of challenge us as clinicians to lean in and learn more and really think about how we foster resilience and how protective that can be to improve the quality of somebody's life. And that foundationally, that's why we do this work. It's for love of people.
Yeah.
Thank you so much for joining us. Again, for our listeners, Dr. Dawn Meichenbaum, you have brought so much wisdom and clarity to this conversation, and I am just so grateful to have had you here sharing your perspectives. Thank you again.
Thank you for the invitation, and I hope it's useful to your colleagues.
Okay, I would hit the stop recording button, but I'll keep recording. Thank you. That was really special and really wonderful. And I love how you integrated about 12 different theoretical models so seamlessly. It was really lovely. And it is no wonder why you are one of the 10 most influential folks in our field. No wonder at all.
So, when did you get into the Miller stuff on the feedback informed treatment?
You know what's funny is I actually, when I was in my master's program, my therapist was an early adopter of FIT. And so I would walk into my own therapy sessions because we were required as part of our program to do, I can't remember how many hours, but I would walk in and she would have a seashell on top of a handout with a pen next to it. And she would start with the 4 questions and then we would end with 4 questions. So that was actually how I got exposed to it, if you can believe it or not. And then I heard Dr. Miller speak at one of the Evolutions of Psychotherapy conferences, the one that was in Anaheim. And I had already been doing some training and integration of his method, but that really kind of cemented it. And now I've worked with Dr. Miller and with Dr. Chow and just adore them. So I love the stuff.
Yeah, I have incorporated a bunch of it, but I tend to use the art of questioning rather than the rating scale
Yeah. Oh,
as
yeah.
a way to get at this. Depending upon the population you're dealing with, there's a real concern about that kind of explicit notation
Yeah,
and the like. And there are multiple other ways to do it.
I agree.
I also take issue with Scott, since we're close friends and the like, in that he thinks that you could use any method, okay, and just use his fit procedures as a way to facilitate change. And I think many of the methods that people embrace are full of hype, and therefore I think there are specific core tasks that
Yeah.
expert therapists need to look at. So I invite you to look at my legacy courses. If not sign up,
Oh, I
well,
would love to.
the money goes to the Melissa Institute anyway.
Thank you. Yes, I
Because,
absolutely will.
and that would be kind of fun if you go right there. I send you, it shows you how you could register and the like.
Awesome. Well,
So if I appreciate if when you send this out to people, if you can include the website address of the Melissa Institute,
yes, absolutely.
as well as Roadmap to Resilience, as well as the kind of, that's roadmap to resilience.wordpress.com, as well as the description of legacy courses.
Absolutely. I'm writing it
Yeah.
down right now. Okay, perfect.
And send me the link when this eventually goes out.
Yeah,
Do you have any
absolutely.
idea when? Is it months or?
My guess would be probably middle end of January. We find this time of year folks are busy, otherwise engaged, and so
Right.
they're less focused
Yeah,
on
that's
new
great.
courses. So probably my guess would be middle to end of January. Please
Great.
excuse me. I have an 11 o'clock client to get to. So I'm going to
Yeah.
hop off, but I will stay in touch with you and make sure that
Yeah.
I have everything
Great.
that I need. I am so honored and grateful. Thank you so much, Don. It's been delightful to talk to you. Thank you for your patience with the issues with Squadcast
Yeah.
and not giving up.
Yeah. No, great. Glad we worked it out. Glad to be of
Fantastic.
help.
Have a
Take
wonderful
care.
day. Okay, we'll be in
You
touch.
too.
Bye. You've just finished listening to another exclusive continuing ed podcast by Clearly Clinical. If you like what you just heard and you need continuing ed credits, please visit us at clearlyclinical.com to check out our one-year membership, where you'll have access to our growing library of continuing ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.